So we know that there are a lot of risk factors for our patients going into surgery. So for something that I do, for example, a hip and knee replacement, this has been studied so well over the last 50 years. I mean, it's gotten to the point now where we can predict risks in a right-handed, redheaded female, who has 4 children. You can predict what the infection risk is going to be. And the data is that granular. So what we've found out is that patients who have, poor nutritional measures have increased risk of not only wound healing problems, which leads to infection, but also things like stroke, heart attack after surgery, pulmonary disease like pneumonia. So all these things that occur after surgery are not only are they going to affect the patient's ability to recover from the surgery, but it's going to have a long-term effect on their health. So for example, somebody who's got a sore hip is walking around limping, they're going to have one set of problems because they don't get exercise, et cetera, et cetera. But if I fix their hip and I've given them a pain-free hip, but now they've had a heart attack as a result of the surgery, have we really made them any better? That's the debate that we face. Now, you mentioned the reimbursement thing. So there's this whole move in medicine away from paying people for service, people being healthcare providers, and instead paying them for outcome. So in the hip and knee replacement space, there was this concept called bundled payments where Medicare said, okay, the episode of care is going to cost about, this much money. This is what we're going to allocate to it. If you can somehow save us money, we'll give you a piece of that savings. Sounds great in theory, but the upshot of what happened was either one of two things. Either practices couldn't manage that well enough and they lost a lot of money, or worse, they decided to cherry pick their patients. And they said, okay, we're only going to operate on the healthiest of the healthiest because we don't want to risk losing money if a patient has a known comorbidity that could lead to a complication after surgery. I don't think restricting access to healthcare is ever the goal in the health system, but that was the unintended consequence. And now with Medicare proposing a 9 to 10% pay cut in 2023, I think the next thing that we're going to see is we're going to see more practices either limiting how many Medicare patients they see or pulling out completely. So what do you do for those patients? As an orthopedic surgeon, okay, that's one issue. But if you're a primary care doctor, if you're a family doctor, if you're an OBGYN or a pediatrician, basically seeing patients on the front line, you're going to have limited access to those patients. So you need to create a methodology by which the patients can help themselves. And I think this is one example of what that type of methodology is.